Hi, my name is Erin Allen, and my evidence-based practice change project addresses the effectiveness of preoperative rehabilitation in anterior cruciate ligament injury management. I am a certified and licensed athletic trainer working in a private physical therapy clinic in Northeast Ohio. I have obtained my Bachelor's of Arts in Athletic Training from Baldwin Wallace University, and I've been practicing as an athletic trainer for the past 3 years now. I am currently pursuing my Master's of Health Science in Teaching and Learning through the University of St. Augustine for Health Sciences. So why this topic? Within my clinical practice, I frequently encounter patients who have sustained an anterior cruciate ligament injury or ACL injury. When the ACL is located within the knee, and its primary function is preventing anterior translation of the tibia in relation to the femur, and also provides rotational stability of the knee. Injury to the ACL commonly occurs in athletics, which is a population frequently treated by athletic trainers, and typically results in surgical intervention followed by an extensive rehabilitation period to return the athlete to their previous level of function. So during this presentation, I will identify the need to improve our current clinical practice guidelines for the management of ACL injuries and present my PICO question that has inspired this clinical practice change project. I will provide a synthesis of the previous research and present the evidence that supports a clinical practice change. To employ the clinical practice change, I have selected a change model that best suits my institution and clinical practice problem. And I will also evaluate the outcome assessments of the evidence-based practice change and how I plan to disseminate the results and sustain this change. I will conclude the presentation with a summary and recommendations for both clinical practice and future research. The clinical practice problem goes back to the prevalence of ACL injuries. In fact, about 200,000 ACL injuries occur each year in the United States, which results in 100,000 reconstructive surgeries, making this one of the most common orthopedic surgeries performed. And according to the National Athletic Trainers Association position statement, the surgical cost of ACL reconstruction ranges from about $5,000 to $17,000 per patient. And then following surgery, participants and athletes usually partake in about 6 to 12 months of rehabilitation. And this results in more medical bills and more time away from play as they try to return to their previous level of function. Yet with such a lengthy rehabilitation program, return to sport rates and the ability to achieve their previous level of function are actually surprisingly low. On average, 2 in 3 participants return to their previous level of function, and only 55% of those returned to their competitive level of sport. There's also a 6 to 32% chance of ACL graft re-rupture upon return to sport, which indicates a need for a secondary surgery. And there's also a risk of a contralateral ACL rupture at a rate of 2 to 20.5%. And according to previous research, patients who have received preoperative strengthening and neuromuscular training had higher functional outcomes and return to sport rates compared to just standard rehabilitation programs. And commonly within the physical therapy realm, patients receive preoperative rehabilitation prior to a total knee arthroscopy to improve post-surgical outcomes, but the same intervention is not utilized for the ACL population. And patients instead quickly receive surgical interventions in hopes of returning to sport quicker. But with the low level of individuals who return to their previous level of function and even a competitive sport, why are we in a rush to get back to competition? And with the high prevalence of ACL tears in the United States, the subsequent high graft re-rupture rates, and decreased functional outcome rates following ACL rehab, I believe there is a substantial need to improve this care and investigate the efficacy of preoperative rehabilitation in addition to traditional care to provide my patients with a well-rounded recovery experience and improve functional outcomes. So my PICO question is for patients who undergo surgical repair for anterior cruciate ligament tears, how effective is preoperative rehabilitation in combination with postoperative rehabilitation compared to conventional postoperative rehabilitation in improving ACL reconstruction outcomes postoperatively and 2 years following surgery? The population of concern is specifically active individuals from the ages of 16 to 40 who have sustained a unilateral ACL tear with no prior ligamentous injury or subsequent meniscal injury, who are also planning to undergo reconstructive surgery with either a bone patellar bone tendon graft or hamstring tendon graft with intentions of returning to full athletic participation. The intervention is preoperative rehab in combination with postoperative rehab compared to the control group, which is just traditional rehab. According to Wilk and Arrigo, the goal of preoperative rehab is to decrease swelling, inflammation, and restore range of motion through a program consisting of quadricep and hamstring strengthening, neuromuscular, and proprioceptive training. And the control group consists of a three-step or three-phase process with restoring range of motion, progressive weight-bearing status, and returning to previous level of function. And then to determine the efficacy of preoperative rehab, the outcome will assess both subjective and objective assessments. So an extensive electronic search was conducted utilizing the University of St. Augustine for Health Sciences library search, which produced a collection of valuable resources. There were several databases found through the university search, as well as PubMed and Google Scholar were searched separately. During my initial search, I utilized keywords using the Boolean operators, which consisted of preoperative rehab or prehab, which highlighted within the title of the articles. And then focused within the abstract, I utilized the keywords of exercise therapy, anterior cruciate ligament or ACL injury, anterior cruciate ligament reconstruction or ACL reconstruction. The initial inclusion criteria was determined within the advanced search option, which limited the results to peer-reviewed academic journals that were also available in full text. They were produced within the last decade from 2009 to 2019 and written in the English language. The inclusion criteria also consisted of the population age from 16 to 40 years old and must be located within the United States. The reports that did not contain human subjects were excluded from this collection. And so the initial search generated a total of 343 articles, and I utilized EndNote, which is a citation manager, to eliminate 65 duplicates, which reduced the total to 278. I then reviewed the title and abstracts of these articles to eliminate any that failed to focus on the influence of preoperative rehabilitation outcomes, specifically being strength, range of motion, or patient-reported assessments. And this reduced the search to 17 articles, and of the articles excluded, many focused on preoperative osteoarthritis interventions, postoperative ACL rehab, or surgical procedures. And then of these 17 articles, an in-depth review was conducted, and 11 more were excluded due to alternative focuses on the ACL rehabilitation. So in total, I came up with 6 articles. 5 of them were original research studies, and 1 was a systematic review. All 5 primary research studies utilized a self-reported outcome measurement, and consistent findings were discovered to support preoperative rehab to improve self-reported knee function and quality of life. Preoperative rehabilitation improved patient-reported knee function prior to surgical intervention, postoperatively, and sustained these improvements at 12 weeks and 2 years following ACL reconstruction. Now, contrasting results were discovered regarding quadricep strength, though. A systematic review and observational study concluded that quad and hamstring strengthening improved following preoperative rehab, but 2 other studies discovered no significant difference in quadricep strength following pre-op rehab, although improvements in quadricep peak torque were noted in these studies. And although there wasn't statistical significance evidence, there was clinical relevance, as quadricep weakness is related to reduced function, quality of life, and increased risk of re-rupture. So therefore, it's clinically relevant that there was an evidence improving quadricep strength. An additional study discovered that preoperative muscle activation improved postoperatively, as well as preoperative strength improved postoperative strength. And one study identified that preoperative strength was a significant predictor for knee-related function, scores 6 months postoperatively. So the randomized controlled trial and systematic review both discovered that preoperative rehab improved functional performance preoperatively and sustained these results postoperatively at the 12-week mark. And superior return to sport rates were discovered following ACL reconstruction 2 years. And overall, the evidence supports that preoperative rehab is a very valuable component in the early stages of ACL injury management, both to overall improve quadricep strength and knee-related function following ACL reconstruction. After an extensive literature review, there is a need for a change in clinical practice. So to employ this clinical practice change, I selected Cotter's 8-step change model. Cotter's model is best suited for both my institution and clinical practice problem due to its emotional and situational components. According to Campbell, implementing a new change into practice when many professionals are involved can cause resistance, but Cotter's mindset of implementing a change addressing these emotions allows clinicians to identify and alter inefficiencies in patient care. So I plan to implement this evidence-based change project in a physical therapy clinic in Northeast Ohio that contains 5 separate branches to ensure that I have an effective patient sample size. And so to establish a sense of urgency, I have to establish an interprofessional team of stakeholders, which will include physical therapists, physical therapy assistants, athletic trainers, physicians, surgeons, patients, and insurance companies. And additional stakeholders will also include clinical administration and marketing staff to help with patient referrals. So to establish this sense of urgency, I plan to first organize the gathered evidence into a handout and present the information to the clinical staff and faculty, potentially in a clinical meeting, to address that there's a need for patient care. And then to establish my powerful coalition, I will communicate and present this previous evidence with stakeholders outside the clinic by collaborating with the marketing staff and have them schedule meetings with the local surgeons and physicians. I will also invite members from diverse professional backgrounds with clinical expertise that share the same sense of urgency for this clinical practice change into this guiding team. So the first step in creating a vision is to highlight the impact on patients and revenue and the success of our clinical practice compared to local clinicians. So sharing this vision focused on preoperative rehab will enhance motivation for a practice change. By utilizing engaging emails to stakeholders, handouts for patient education, and presenting at these monthly clinical meetings and physician meetings, I could also host a question and answer session to promote understanding, motivation, and comprehension among the team, which is going to be the best way to communicate this vision we've created. Within the clinic, physical therapists and athletic trainers will be encouraged to make their own clinical decisions and progress each patient to help them act on this vision and to provide patient-centered care. And physicians will be regularly corresponded with regarding patient progression and outcome measures to ensure that this practice change is strictly benefiting the patient. And then to create and plan for short-term wins, documentation of these patients' successes and progressions through the preoperative treatment, comparing both baseline and post-intervention measurements and communicating this data with the stakeholders will help them recognize the significance. And comparing both these measurements, both short and long term, with the preoperative and baseline measurements, we'll be able to highlight the improvements and plateaus within the treatment. So following the implementation of preoperative rehab, I plan to determine the best protocols for preoperative rehab to achieve the most significant patient outcomes and sustain this clinical practice change and alter our clinical practice guidelines. That's how I plan to consolidate the improvements and produce more change and institutionalize new approaches. So to determine the influence preoperative rehab has on ACL reconstruction outcomes, I will utilize the International Knee Documentation Committee Subjective Knee Form, which is a knee-specific self-reported outcome assessment used to measure symptoms, function, and sports activity. This is a questionnaire frequently utilized by researchers and clinicians to measure patient-reported function due to its reliability, validity, and responsiveness for patients who have sustained an ACL injury. To assess quad and hamstring strength, I plan to utilize an isokinetic dynamometer, which is frequently used in previous research as well and is a standard clinical assessment tool. Isokinetic dynamometers are valid and reliable assessments to measure muscle strength and is referred to as the gold standard for assessing just plain muscle strength. To assess functional performance of the lower extremity, I will use a battery of tests called the single leg hop test, which will include the single leg hop test for distance, crossover hop test, triple hop test, and the 6-meter timed hop test. The single leg hop test is the gold standard for assessing knee functional status and measuring functional performance. And according to the previous research, the single leg hop test is more reliable than isokinetic testing to measure functional strength in recovery following ACL reconstruction. This functional assessment is also one that I have frequently utilized in my workplace. Time to return to sport will be the time recorded following ACL reconstruction to the time the physician or surgeon releases the athlete to full participation. I have previously performed all of these outcomes and am familiar with all the testing procedures, so I will conduct the assessments along with experienced athletic trainers and physical therapists to decrease the influence of raters' knowledge and skills on assessment outcomes. Outcome measurements and data collection will occur at 4 distinct time points, which will include baseline measurements, pre-operatively just before ACL reconstruction, post-operatively, which will be 12 weeks into traditional rehab, and 2 years post-reconstruction surgery to determine the long-term efficacy of preoperative rehab. I plan to assess patient-reported outcomes, functional performance, and quadricep strength at all 4 of these distinct time points, but time to return to sport will just be assessed at the post-operative time frame when the athlete is returned to sport, and it will be measured as a mean plus or minus standard deviation. The outcomes will be measured in both the comparison and intervention groups to determine the efficacy of this intervention. The International Knee Documentation Committee Subjective Knee Form is a Likert scale and is considered to be nominal scale of measurement. Measurement of isokinetic strength is measured as peak torque values, as well as time of return to sport is measured in months, and single leg hop test is measured in centimeters, which all are considered to be a ratio scale of measurement. And due to the existence of multiple variables to identify an improvement in ACL outcomes, I plan to utilize SPSF software to determine if statistical significance exists, to determine the difference between the intervention and comparison group in quadricep strength, self-reported outcomes, and functional performance. At the 4 distinct time points, a repeated measure analysis of variance will be used specifically, and an unpaired t-test will be used to assess the differences between the 2 treatment groups consisting of different individuals to analyze the rate of return to sport in both groups. If the data analysis shows that the practice change was successful in producing the desired outcomes, I plan to provide detailed data and patient narratives to stakeholders to prove the efficacy of preoperative rehab firsthand and to further motivate stakeholders to sustain this clinical practice change. I will present the results at my institution in clinical staff meetings with stakeholders, presenting the results face-to-face by creating a visual representation, which will display the patient outcomes from the distinct time points and demonstrate patient improvements following preoperative rehab, and the need for a clinical practice change. With the assistance of our clinical marketing staff, I will conduct a seminar with local physicians to present the results discovered within our clinic. And then the presentations will address the successful patient outcomes following the implementation of preoperative rehab and capture the potential for long-term benefits 2 years down the road. And athletic trainers are important stakeholders as they often work with athletes who have sustained an ACL injury. And so since I plan to initiate the EBP change in a physical therapy clinic in Ohio, I would deliver the presentation to the Great Lakes Athletic Trainers Association annual meeting to reach out to other professionals who are trying to advance best practice outcomes and deliver the best approaches for treatment. I will also plan to disseminate my results at the national level at the National Athletic Trainers Association Clinical Symposium, presenting a professional presentation to increase stakeholder motivation and sustain the clinical practice change. Physical therapists are another important stakeholder, and so I plan to reach this professional population by presenting at the American Physical Therapy Association National Conference to provide professionals with valuable information regarding the significant improvements to our current clinical practice with the implementation of preoperative rehab. I have selected a popular journal with the same mission of enhancing patient-related outcomes, which is the Journal of Orthopedic and Sports Physical Therapy, because my goal is to modify clinical practice guidelines to improve the conventional management of ACL injuries. All 5 primary research sources and systematic review of literature recommend and support the use of preoperative rehabilitation into ACL injury management, and improvements in self-reported function and quadriceps strength were consistent following the implementation of a structured rehab program. And it indicates a need for clinicians to address quadriceps strength and activation in the early stages of ACL management. So preoperative rehabilitation is warranted once initial symptoms of ACL rupture have subsided to improve quadriceps strength preoperatively and self-reported function postoperatively. Additionally, implementing a rehabilitation program in the early stages of ACL management will be beneficial for clinicians to determine if surgical intervention is necessary to ensure that we are providing patient-centered care. Prior research utilizes a variety of exercise approaches, yet there are consistent improvements, so further research is needed to determine the best preoperative rehabilitation approach and preoperative protocol. According to Ebel et al., these practice recommendations are considered a level A due to the presence of 1 randomized controlled trial and a systematic review of 8 randomized controlled trials that discovered consistent improvements following the implementation of preoperative rehab. Therefore, preoperative rehab is a very valuable component in the early stages of ACL management to improve quadriceps strength and knee-related function following ACL reconstruction. And the addition of preoperative rehabilitation in combination with postoperative rehab improves ACL outcomes both postoperatively and 2 years following surgery. In summary, there is a clear need to improve patient outcomes following ACL injury and subsequent rehabilitation to improve function, quality of life, and quadriceps strength. My PICO question, to reiterate, compares preoperative rehabilitation in combination with postoperative rehab to traditional care. Cotter's model of change is best suited to allow clinicians to address and alter inefficiency in clinical practice to improve patient outcomes for this specific population. And utilizing reliable and valid outcome measures will help disseminate my results to change institutional, local, national, and regional clinical practice and encourage a change to implement preoperative rehabilitation into the injury management of ACLs. This presentation concludes with strong recommendations to implement preoperative rehabilitation and identifies the need for further research to determine the most effective preoperative rehabilitation program. The following slides are references for all original research, systematic reviews, and materials included in this presentation. Thank you for your time and attention. If you have any questions, please feel free to contact the email on this page. I hope you enjoyed the presentation and understand the importance and significance of implementing preoperative rehabilitation with traditional rehabilitation to improve postoperative outcomes for ACL management. Thank you.